I was not just pleased but very impressed by his unique approach towards treating his patients. He is passionate about the work he does, the care and well-being of his patients. That too with a great sense of commitment, devotion and service. To me, these are a much needed ingredient to be a doctor in its true sense. And if all that is backed with an educational background and experience such as his, the recipe for success, which of course he is successful. Dr. Ramon Gil is a board-certified neurologist and certified internal medicine practitioner. He has been serving the Southwest Florida area since 1989. He has always had special interest for movement disorders, in particular Parkinson's disease and related conditions like tremor, spasticity, and dystonias. He was the medical director and one of the founding members for the Movement Disorders Society of Southwest Florida. In recognition for his performance on behalf of patients afflicted with these disorders, in March of 2000, he was appointed as the clinical associate for the National Parkinson's Foundation. He was appointed as member of the local organizing committee for the 18th World Congress on Parkinson's disease and related disorders. Today, he is a well-known name in the clinical skills and in field of neurology. On a regular basis, Dr. Gil participates in educational community programs. His main office is in Port Charlotte, Florida, and he has 2 satellite offices, Venice and in Cape Coral. With no further ado, let's welcome Dr. Gil.
Is what we consider the best way to treat Parkinson's disease today. There has been such a tremendous amount of information and advance in this field within the past 20 years that, just to give an idea, back in 1998, the American Academy of Neurology asked a subcommittee from the Movement Disorder Society to put together a supplement for our journal just to report what was going on in Parkinson's, what was an update in the management and so on. And that was very, very well received because there was a lot of new information. Well, 2 years later, it had to be done again. And for the 3rd time, it was presented in 2003. So, to talk about Parkinson's disease today is really a very, very, very different presentation that when I was in residency or when I started my practice or 10 years ago or 5 years ago, and in many ways from yesterday. So I would also like to present here some basic information in terms of what some of us believe is the way to treat not just Parkinson's disease, but any type of chronic illness, especially neurological, for reasons that we will discuss later. And it is with a true holistic approach. This is not just medication, this is not just basic healthcare and nutrition. This has to be expanded to other disciplines like physical therapy, speech therapy, but more important, non-conventional therapies like yoga, Tai Chi, and other things that we could discuss later on, which is what brings me close to Mrs. Kumar. This line is from Dr. Rana, who is one of the well-known figures in the World Parkinson's Association. And he says, very simple, but something that is very, very true. Those who fight Parkinson's with knowledge always find solutions. And for us at our group, education, working with our patients, making them familiarized with what Parkinson's disease is all about is critical, because it is most important for these patients to understand the disease, to feel that they really control this and not that the disease controls them. And education is the only way that they will be able to drive the vehicle knowing where they are going and knowing what to do in cases of any type of changes in their condition. Now, to describe to you what Parkinson's disease is, this may be a way to do it. This is a chronic progressive neurological condition in which patients over time experience a slowness of movement, they have a stooped posture, they may have some tremor, which typically start in one side and a few years later goes to the other side. They have in advanced stages or more advanced stages of the disease balance problems and unsteadiness, and they may suffer falls, which may become a very serious problem. When one examines patients with Parkinson's, they have also rigidity in their limbs. Now, that is the way we traditionally feel and think about Parkinson's disease. But in reality, we were for many, many years missing the boat. By the time we diagnosed Parkinson's disease with those typical motor signs, the disease has been affecting the body for more than 15 years. And now we have learned a lot about the preclinical stages of Parkinson's disease. And in the early 2000s, a physician, anatomist from Germany, Dr. Bragg, did a fascinating study and demonstrated that the first part of the brain that is affected by Parkinson's disease involves the olfactory bulbs, or the area of the brain that perceive a smell. And that is what we consider the stage 1 of the disease. Now, from that moment to the moment the patient develops a little bit of tremor or a slowness in the movement, at least 5 to 6 years pass by, bringing us to a stage 3 or 5, which is when the symptoms are manifested. So we have been for years treating Parkinson's disease after the disease has been evolving and affecting different organs in the body. As a matter of fact, when Dr. Bragg described stage 1 of Parkinson's, he's talking about involvement of the brain. But by then, other organs have been affected, like the large intestine, which is why constipation precedes the onset of Parkinson's disease easily for 15, sometimes 20 years. Now, I am not saying that constipation is necessarily an indication for Parkinson's, but when you look in retrospect, more than 90% of the patients with Parkinson's disease have been experiencing chronic constipation for a number of years. And there was a famous study performed in Honolulu where they did a similar analysis of what they did in Framingham, which they basically follow a group of subjects in a population for years, and they basically collected demographic information. And they basically learned how many people develop diabetes, how many people develop cancer, high blood pressure, etc. And then investigators could go back and analyze the data and learn from that. So when the investigators looked at the population of patients in that cohort of subjects that develop Parkinson's disease, they say, well, let's look now for common denominators. What is the most significant indicator that patients will develop Parkinson's disease in the future? And not surprising, in that study, constipation was the #1 predictor of patients developing Parkinson's disease down the road. So here we have the typical motor symptoms, but more importantly, we have a list of the non-motor symptoms of Parkinson's. And I mentioned for you that the typical motor symptoms were the tremor, the rigidity, the slowness of movement, and then the balance problems and falls. Now, the non-motor symptoms have become more and more important for us for many reasons. Number one, many of them come on or develop even before, way before we had motor symptoms. For example, mood disorders like depression and anxiety is present in more than half of the patients with Parkinson's disease within a year from being diagnosed with Parkinson's. Again, I am not saying that a patient who develops depression necessarily means that he or she is going to develop Parkinson's. But realistically, we in different fields in medicine have learned to identify what is called organic depression and take that very seriously. No one should just become depressed because the blue sky. There has to be a reason, and if you don't have something called reactive depression, if the depression comes on for no apparent reason, there is a need for you and your primary care physician to discuss things. There could be an endocrine disorder like diabetes, cardiac problems, cancer, or maybe neurological conditions like Parkinson's, Alzheimer's, etc. So another very important thing that we have learned to identify includes what we call autonomic problems. And autonomic problems in Parkinson's means or indicates involvement of the part of the nervous system that controls automatic functioning. Constipation, bladder problems, sense of smell, but in many other cases, patients experience problems with sweating. They have drenching sweat, it's called. And many of these patients experience sleep disturbances prior to developing the motor symptoms of Parkinson's disease. And this is all important because the goal that we have today in the treatment of Parkinson's disease is to diagnose the disease before the motor symptoms come on. So we could intervene before the brain is damaged. So we are now developing more information or exploring the development of drugs that could prevent effectively the progression of the disease. And why is that? Is because we know today that the culprit in Parkinson's disease is an abnormal protein called alpha-synuclein. So if we are able to stop the excessive production of that substance and the deposition in the neurons and in other tissues in the brain and in the body, we may be able to arrest the disease, which is a fantastic goal, especially if we are able to catch this before it goes to the brain. These are, again, a variety of non-motor symptoms that patients with Parkinson's disease may experience. And they are critical not only in the preclinical stage of the disease, but also when patients have more advanced disease, we are able to improve the control of the motor symptoms, recognizing non-motor symptoms. In other words, as the medication wears off and the symptoms tend to reemerge, many patients will experience not only reemergence of the tremor, but they may become anxious, apprehensive, they may have changes in the mood, they may also experience bladder symptoms, etc., that give the patients and the doctors an idea in terms of how well controlled the disease is symptomatically. Now, we have done extremely well treating Parkinson's disease in the sense of the motor symptoms. We have made a lot of progress to the extent that a few years ago, when a person with Parkinson's disease was diagnosed with this condition, they have a lifespan of 8 to 9 years. And I am talking about in the early, mid-1970s, that was the case. And painfully, there are some publications out there that obviously are not, in my opinion, particularly well founded. And a few years ago, like 3 years ago, I received a booklet from one of the health insurance companies still disclosing that information, that the lifespan of a patient with Parkinson's disease was 8 to 9 years from the diagnosis. That is completely false. The lifespan of patients with Parkinson's disease today equals the lifespan of patients with no Parkinson's, which is a remarkable progress because that has been achieved based on new drugs, based on better information, based on better understanding of what goes on with this disease and how can we optimize the treatment and improve the patient's functional status. These are some of the medications that we typically use for Parkinson's disease, levodopa, which you see in the top, continues to be the most commonly used drug for the treatment of Parkinson's. It is the most effective symptomatic drug, but it has some pros and cons like anything else. And the reality is that in the 1990s, we learned that if patients, selected patients, were treated with another family of drugs called dopamine agonists during the early stages of the disease, and levodopa was introduced later, that change in the treatment will lead to delay in the onset of what we consider the most problematic challenge in terms of the pharmacologic treatments, which are the motor fluctuations and all these dyskinesias or involuntary movements that some of you have seen Michael J. Fox, for example, display. In other words, using dopamine agonists first, we are able to delay the onset of these complications because we believe today that a lot of that is created not only by the disease progression, but because of levodopa works for a very limited period of time, and then the areas of the brain affected by Parkinson's and the areas of the brain that are responsible excuse me, for the response to the drug, for the dopamine, are damaged by the stimulation that is pulsatile. In other words, the short-acting drugs, on and off, on and off, on and off, deregulate these areas of the brain, and then the response a few years down the road is not as smooth as we would like. So using longer-acting drugs that will stimulate these areas called dopamine receptors, those longer-acting drugs provided more tonic or a stable stimulation, and the disease or the treatment has a much better response, and patients don't experience as early as otherwise these motor complications. And then there's a whole array of different drugs that we use in combination to optimize the treatment and minimize side effects. Now, the big question is, how can we treat patients protecting the brain tissue? What can we do to change or alter the course of the disease in such a way that when I go to heaven, if I want to go to heaven, I will be able to enjoy a good quality of life to my last day. How can I protect the brain? And that has been a very, very debated and explored field. And there have been several drugs that have been created with the idea of changing the chemistry of the brain and reduce, for example, the formation of free oxygen radicals. Free oxygen radicals are chemical substances that in the brain lead to the death of the cells that produce dopamine. So we don't want free oxygen radicals in the brain. That's why you have heard so much about antioxidants, vitamin E, vitamin C, etc. Well, there was a whole family of drugs created with this idea, and unfortunately, to this day, they have not been able to prove that they truly protect the brain. There are studies showing some changes in the clinical course. There are studies showing that they may give the patient a better clinical course, but a true evidence of neuroprotection has not been able to be demonstrated with the use of these drugs. And what we would like to see is evidence not only in the clinical examination of the patient, but also we would like to see more dopamine in the brain of these patients if what you are doing is protecting the brain. Or you would like to demonstrate with a special pictures of the brain that when you use these drugs, dopamine remains longer in the brain than in those patients that you did not use those drugs. That has not been able to be effectively proven with medication. Now, in the overall management of Parkinson's disease, again, we talk about great progress, treating the tremor, treating the rigidity, the slowness, patients do much better, and the quality of life has certainly improved tremendously. But there are still two tremendous challenges here: balance problems and faults and cognition. We know today that 30 to 40% of the patients with Parkinson's disease will develop dementia. In other words, today we realize that Parkinson's disease is a dementing illness, and the figures could change depending on the population. If you look, for example, at patients who develop the motor symptoms of Parkinson's in the 70s, mid-70s, or late 70s, that group will develop dementia in up to 80%. So that's a big challenge for us, because when a patient develops dementia, a whole set of complications occur. We are better than that. And I don't need to tell you, obviously, that faults are associated with injuries, fractures, and then hip fractures in patients with neurological conditions is associated with a very high increase in the mortality and morbidity for the year following that fracture. So we certainly have a big problem there. Now, here is the interesting part of the holistic approach. We have learned through many different studies the value of physical activity and physical fitness. And this was a study in which a large group of nurses, healthy nurses, were followed over time. And these were a group of volunteers that were just followed over time to see what will happen with their health as they grew older. And we learned from this study that women with higher levels of activity show better cognitive performance and 20% lower risk of cognitive impairment than women that will have just a passive lifestyle. And the Honolulu Asian study that I mentioned before also demonstrated that men who walk the least experience 1.8-fold risk of dementia compared with those who walk more than 2 miles a day. So these are impressive numbers just to think about physical activity. This is something that alters significantly the incidence of dementia and cognitive problems in patients in general. Okay? And here is another interesting thing that was published in Alzheimer's population, just showing that if patients maintain a physical activity of 150 minutes a week, 150 minutes a week of moderate exercise, the incidence of dementia significantly reduced. There is, by the way, another interesting evidence that if you take patients around the age 50 and you force them to learn a very difficult task like a second language at the age 50 or around 50, or to play a musical instrument, the incidence of Alzheimer's is reduced tremendously in that group of patients. So that will link later on with a concept that I will mention called neuroplasticity. So what can we do to prevent Parkinson's? What can we do to delay the complications of this disease that are so challenging for us? Balance and cognition. What can we do to reduce the incidence of Alzheimer's? Well, that's the best evidence that I can show you today in a quick summary. Exercise, exercise, exercise. And I'm going to tell you, this is not just for the... Yeah, I know.
Okay.
Yeah, that's why I'm running quick. So, when we did our recent program, we presented a session for Tai Chi, which brings to the pie not only the flexibility and the balance exercises, but also help patients to combine mind and body more effectively. This is not just a matter of you take this pill and you will do fine. If you look for ways in which you could exercise, even with your physical limitations, and Tai Chi offers that, it will add to your treatment tremendous value and benefits. Yoga has been amazingly helpful for many patients with Parkinson's disease. And you recognize our instructor. And I will tell you, I am ashamed to tell you that I should have been asking Mrs. Kumar for help a long time ago. And if you click, or if you Google, like the fancy word today, Google, yoga and Parkinson's disease, you will be surprised. There are close to 800,000 citations of bunch of publications around the world of the value for this intervention. Dance therapy. There is no better way to exercise than dancing. And it has been proven, not just by us here, but Emory University, the NIH, Rush Presbyterian, University of Maryland. They have done studies, and you take patients who suffer heart attacks, and they have a bypass, and they are all in a treadmill in cardiac rehab after the whole hospitalization. But 6 months after, half of them are gone, they are not going back to the gym. But if you put them to dance, the partner will make sure that they continue. And that has been shown to be very effective for Parkinson's. Flexibility, balance, timing, and patients stick to the program much longer than just going to a gym. And here is an amazing patient of ours. He is Peter Gaylor, and he is a commercial pilot. He is in his late 50s, and this guy has had Parkinson's for 10 years. And what he has done with physical fitness is just unbelievable. This guy won't have a problem with Parkinson's. I guarantee you. He has been able to improve his balance and coordination. He does things and exercises that most of us are unable to do. And guess what? Exercises will help you symptomatically for sure. Neuroprotection, which we discussed, is very likely to be achieved based on what we have learned. And then neuroplasticity means that through exercises you are able to open new channels, new networks of neuronal connections that will be able to help you with the problems with Parkinson's disease. There are no side effects from exercises, no insurance required, no drug interaction, no doctor's prescription, and you will improve your motor symptoms of Parkinson's. And then, just to finish here, this is Parkinson's disease. This gentleman came to us being treated for Parkinson's at a major facility, and this is him after we treated him.
Wow. After how long?
Wow.
That is within 4 months.
4 months.
Wow.
4 months with Viva?
Sign me up.
He was a pilot?
Yes.
Can he still fly?
Oh yes, yeah.
Wow.
He has no problem. I mean, again, but he does that with exercise and a good regimen of medication.
Doctor, we want to thank you for coming.
Thank you very much.
And as